Welcome to the Deep Dive. We take complex topics, sourced directly from specialized materials like textbooks and research, and we break them down, really try to make them digestible and actionable, especially for you.
And today we're doing a deep dive into a really intricate area, abdominal endocrine and neuroendocrine disorders. We're drawing heavily from a specific chapter in a key surgical text.
Right, so think about how our bodies maintain balance, homeostasis. It's largely down to two big communication systems.
Yeah,
The endocrine and the neuroendocrine systems.
exactly. They use chemical messengers, peptides, amines, steroids, that sort of thing, to talk to target organs all over the body. It's this complex signaling network.
The endocrine system is probably the one most people think of first, ductless glands, like the thyroid or relevant today, the adrenal glands. They secrete hormones straight into the bloodstream.
Hormones travel far and wide. But then you've got the neuroendocrine system. It's a bit of a hybrid, really fascinating. Well, it involves neuroendocrine cells. These can be stimulated by nerve signals, like neurons, but they release their messengers, neurohormones, into the blood, acting like hormones.
Ah, okay. So nerve input, hormone output.
Precisely. And these cells aren't all clustered in one gland. They're kind of scattered, particularly in the GI tract, the pancreas, the islet cells, and even the thyroid. Together, they form what's called the diffuse neuroendocrine system.
And the source material points out this interesting historical link, doesn't it, between cells in the adrenal medulla, the gut, and the pancreas.
Yes, the ATUD cell concept, amine precursor uptake, and decarboxylation. The old idea was they all shared a common origin from the neural crest during development.
Which has been updated a bit.
Yeah, modern embryology shows it's more complex than a single shared origin for all of them. But the key point the source makes is that they do share a common neuroendocrine programming influence during their differentiation.
And that shared programming isn't just an interesting factoid, it has real practical consequences.
Huge consequences. A really critical shared feature is the presence of somatostatin receptors, SSTRs, on the surface of many of these neuroendocrine cells.
SSTRs. Okay, that sounds important. Why?
Because those receptors give us a target. We can design radioactive tracers that bind specifically to SSTRs. Think gallium-68 Dodotaki PET scans. They light up these tumors beautifully.
So for diagnosis and localization.
Exactly. And also for therapy. We can use drugs like somatostatin analogs, which bind to SSTRs and can slow tumor growth or hormone secretion, or even attach radioactive isotopes to these drugs for targeted radiotherapy, hitting the tumor cells directly.
That really highlights why specialists in nuclear medicine and radiopharmaceutical therapy are so vital in the team managing these conditions. It's molecular biology directly impacting patient care.
Couldn't agree more. It's a prime example of bench-to-bedside translation.
And speaking of management, the source lays out a very clear, sort of stepwise approach for endocrine surgery in general, like a fundamental framework.
It really is. Think of it as the core principles. First, you absolutely have to confirm the diagnosis biochemically.
Before jumping to conclusions based on imaging.
Absolutely. You need the blood tests, the urine tests, whatever it takes to prove there's an excess or deficiency of a specific hormone. Is aldosterone truly high? Is cortisol out of whack? Are catecholamines elevated when they shouldn't be?
Okay, step one, biochemical proof. What's next?
Step 2, make the patient safe. These hormonal imbalances can be really dangerous. Severe high blood pressure, dangerously low blood sugar, critical electrolyte problems like low potassium. You have to manage these acute risks before you proceed further.
Makes sense. You wouldn't operate on someone in a hypertensive crisis from a phaeochromocytoma, for example.
No way. Stabilize first. Then, step 3, localization studies. Where is the problem actually coming from? Is it a single tumor? Is it both glands? Is it diffuse?
So CT, MRI.
Yes, those are the workhorses. But as we'll see, sometimes you need more specialized tests, like adrenal vein sampling, to pinpoint the source, especially when deciding between unilateral and bilateral disease.
Got it. Step 4.
Decide if surgery is actually the right treatment. Not every adrenal nodule needs removal. Maybe medical management is better, or even just observation.
And if surgery is indicated.
Step 5. Determine the best operative approach. Laparoscopic, open, through the abdomen, through the back. That depends on the suspected disease, tumor size, location, and potential for malignancy.
So those 5 pillars, biochemical confirmation, patient safety, localization, surgical indication, and operative approach. We'll see these playing out as we discuss specific conditions.
Exactly. They're the recurring themes, ready to start building that foundation. Let's get into the anatomy and physiology of the adrenal glands themselves.
Let's do it. So these are paired glands sitting like little caps on top of the kidneys. Pretty small, only about 4 grams each.
And they're tucked away deep in the retroperitoneum behind the main abdominal cavity lining, nestled within that fatty layer around the kidney called Gerota's capsule.
You mentioned earlier they aren't symmetrical and that this matters surgically. Can you elaborate?
Yeah, their neighbors are different. The right adrenal is kind of wedged between the liver, the diaphragm, and importantly, the inferior vena cava, IVC, the body's main vein. They can even sit partly behind the IVC.
Okay, close to a major vessel.
Very close. The left adrenal, though, is typically more superior and medial to the left kidney. It's often covered by the tail of the pancreas and the spleen.
So different landmarks, different structures to work around for the surgeon.
Definitely. And their blood supply is interesting, too. They get blood from lots of small arteries, branches from the aorta, the inferior phrenic artery, the renal artery is a very rich supply.
But the drainage is simpler.
Usually, yes. Typically, there's one main large adrenal vein draining each gland. And knowing where that vein is and controlling it is probably the most critical step in the surgery.
Where do they drain?
The right adrenal vein is short and drains directly into the IVC. The left adrenal vein is usually longer and drains into the left renal vein. That anatomical difference is key.
Okay, and the source also mentions tissue outside the adrenals that's related to the extraadrenal paraganglia.
Right. These are clusters of neuroendocrine cells similar to those in the adrenal medulla, but located along the sympathetic nervous system chain or associated with parasympathetic nerves.
Like the organ of Zuckerkandl.
That's a classic example, near the aortic bifurcation. Others are found near cranial nerves, like the carotid bodies which act as chemoreceptors. The source categorizes them based on location and type sympathetic, chemoreceptor, and so on.
And tumors arising from these paraganglia are called paragangliomas, PGLs.
Exactly. So a phaeochromocytoma is specifically a tumor of the adrenal medulla. A paraganglioma is essentially the same type of catecholamine-producing tumor, but arising from these extra-adrenal sites.
Got it. Pheo in the adrenals, para outside.
Pretty much. And their behavior can differ. Sympathetic PGLs usually secrete hormones, while parasympathetic ones, like those in the head and neck, often don't.
Okay, let's zoom back into the adrenal gland itself. You mentioned 2 distinct parts, cortex and medulla. Tell us about their origins and structure.
It's fascinating. They have different embryological origins. The outer cortex, about 90% of the gland's mass, develops from mesoderm.
Like connective tissue and muscle.
Right. But the inner core, the medulla, develops from ectoderm specifically, from neural crest cells that migrate in. These become the chromaffin cells, the ones that stain with chromium salts.
So 2 fundamentally different tissues fused into one organ, and the cortex itself has layers.
Yes. 3 distinct zones in the adult cortex, each producing different steroid hormones.
Yep.
The outermost is the zona glomerulosa.
Glomerulosa. Sounds like kidney related.
Good connection. It secretes aldosterone, the main mineralocorticoid, which acts primarily on the kidney tubules.
To control salt and water balance, right?
Yeah.
Sodium retention, potassium excretion.
Precisely. It's key for blood volume and blood pressure regulation. And importantly, its secretion isn't primarily controlled by ACTH from the pituitary, like the other cortical hormones.
What controls it then?
Mainly the renin-angiotensin system and the potassium level in the blood. When the kidneys sense low blood flow or low sodium, they kick off the renin cascade, leading to angiotensin II, which strongly stimulates aldosterone release. It's a feedback loop crucial for fluid balance.
Okay, so glomerulosa makes aldosterone. What's the next layer?
The middle and largest layer, about 70% of the cortex, is the zona fasciculata. This is where cortisol is made.
The major glucocorticoid, the stress hormone.
That's the one. Cortisol production is controlled by ACTH from the pituitary, which itself is controlled by CRH from the hypothalamus. It's a classic HPA axis hypothalamic pituitary adrenal.
With negative feedback.
Yes. High cortisol levels feed back to suppress CRH and ACTH release. And cortisol's effects are incredibly diverse, touching almost every system.
Like what specifically? What do we see clinically when it's high or low?
Oh, it affects metabolism, increases blood sugar, breaks down fat and protein. It suppresses inflammation and the immune system. It influences fat distribution, like causing central obesity. It affects bone, skin, wound healing, mood, sleep, alertness, you name it. That's why Cushing syndrome, excess cortisol, has such widespread symptoms.
Okay. And the innermost cortical layer.
The zona reticularis. This produces adrenal androgens like DHEA and DHEAs. These contribute to secondary sexual characteristics, especially in women, and their production is also regulated by ACTH.
So 3 cortical zones, 3 main types of steroid hormones. What about the medulla, the inner part?
The medulla, made of those chromaffin cells, is essentially part of the sympathetic nervous system. It makes and secretes catecholamine.
Adrenaline and noradrenaline.
Mainly adrenaline, about 80%, because it has the enzyme PNMT to convert noradrenaline to adrenaline. Unlike nerve endings that release neurotransmitters locally, the medulla dumps these catecholamines directly into the bloodstream, acting as hormones.
Triggering the fight or flight response systemically.
Exactly. Increased heart rate, blood pressure, blood flow to muscles, bronchodilation, mobilizing glucose, all the classic effects mediated by alpha and beta adrenergic receptors.
Yeah.
A rapid, body-wide alert state.
That detailed physiology is crucial background. Now let's connect it to a very common clinical scenario, the adrenal incidentaloma, the unexpected adrenal mass found on a scan.
And they really are common. The source says about 3% prevalence on scans by age 50, jumping to 10% in the elderly. Autopsies suggest maybe even higher. So you find one, and the immediate questions are, what is it? Is it benign or malignant? And is it producing hormones?
That's where that systematic approach comes in again, assessing malignancy risk and functional activity in parallel.
Right. For malignancy risk, imaging characteristics are key. Size matters, bigger is generally more concerning, but density on non-contrast CT is very helpful. Benign adenomas are usually lipid-rich, so they look dark, low density, typically 10 Hounsfield units or less.
So A10HU is reassuring.
Generally, yes. If the density is higher or indeterminate, then you look at other features. How quickly does it wash out contrast dye on a CT scan? Malignant lesions tend to hold on to contrast longer. Relative washout 40%, absolute 60%. Does it lose signal on out-of-phase MRI images? If it doesn't, that suggests low lipid content, which is more suspicious. Does it light up brightly on an FDG PET scan? High uptake suggests high metabolic activity, another worrying sign.
And clinically.
If the incidentaloma is found in someone already showing signs of Cushing syndrome or viralization, the chance of it being malignant is higher.
Okay, that's assessing malignancy risk. How about function?
You need to screen biochemically for the most common types of adrenal hormone excess, even if the patient has no symptoms. That means a 1 milligram overnight dexamethasone suppression test for subclinical Cushing's, plasma or urinary metanephrines for phaeochromocytoma, and the plasma aldosterone-renin ratio, AR, for primary hyperaldosteronism. If signs suggest it, you'd also check sex hormones.
So you gather all this information, imaging features, biochemical tests. What's the management algorithm?
It really hinges on those findings, ideally discussed by a multidisciplinary team. The good news is, if it's small, say less than 4 centimeters, looks clearly benign on imaging, low density, and is non-functioning based on the biochemical screen.
Then you don't necessarily need surgery.
Correct. The initial approach is typically observation. The source suggests a follow-up CT or MRI in about 6 months to ensure stability. There's less consensus on long-term follow-up after that, but it notes that tumors over 3 centimeters might have a slightly higher chance of developing hormone production later.
When is surgery indicated for an incidentaloma?
Definitely if it's causing hormone excess Cushing's, Conn's, phao, regardless of size, assuming it's unilateral. Surgery is also generally recommended for tumors larger than 4 centimeters, even if non-functioning, because the risk of malignancy increases with size. And of course, if it has any imaging features suspicious for malignancy, or if it shows significant growth on follow-up scans.
And the surgical approach, again, depends on that assessment, following that algorithm in figure 57.2.
Exactly. Laparoscopic adrenalectomy is the standard for most benign or potentially malignant tumors that are smaller, say less than 6 centimeters, and don't look invasive. But if malignancy is strongly suspected, especially if it's larger or looks like it's invading nearby structures, then an open adrenalectomy is usually the safer oncological approach.
It really illustrates how you apply those core principles: biochemical function, malignancy risk assessment, surgical indication, and approach selection, even for something found by chance.
Perfectly put. Now let's dive into some specific disorders of the adrenal cortex, starting with primary hyperaldosteronism, or Conn syndrome.
So this is the adrenal gland making too much aldosterone on its own, right? Independent of the renin system.
Precisely. And it's incredibly important because, as the source highlights, it's the most common cause of endocrine hypertension. It might be present in up to 20% of all hypertensive patients and even more in those with drug-resistant high blood pressure.
Then why is that significant?
Because excess aldosterone doesn't just raise blood pressure. It directly damages the cardiovascular system and kidneys, increasing the risk of stroke, heart attack, atrial fibrillation, even diabetes and metabolic syndrome. But if you diagnose it and treat the underlying cause, you can often cure the hypertension or significantly reduce medication needs and lower those risks.
What are the underlying causes? Is it always a tumor?
Not always. The most common cause, in about 30–40% of cases, is a benign tumor called an aldosterone-producing adenoma, or APA. But another major cause is bilateral adrenal hyperplasia, BAH, where both glands are overactive. Much rarer causes include adrenocortical cancer, unilateral hyperplasia, and several inherited familial hyperaldosteronism FH syndromes.
And knowing the cause unilateral APA versus bilateral BAH is critical for treatment, I assume.
Absolutely fundamental. Unilateral disease, APA, is typically treated with surgery. Bilateral disease, BAH, is managed medically. Getting that distinction right is paramount.
The source mentioned some interesting genetics behind the APAs.
Yes, most sporadic APAs have acquired somatic mutations within the tumor itself. The most common mutation, found in about 40%, is in a gene called KCNJ5, which codes for a potassium channel. This mutation seems to trigger calcium influx into the cell, stimulating both aldosterone production and cell proliferation. These KCNJ5 mutated tumors tend to occur more in women, be larger, and produce more aldosterone. Other less common gene mutations are also found.
What about the bilateral form, BAH? Is it just diffuse enlargement?
Traditionally, yes, but the source note's emerging evidence suggests it might often be driven by tiny clusters of aldosterone-producing cells, maybe even micro-APAs within both glands, possibly linked to different genetic mutations like CACA1D. The understanding is evolving.
And the rare familial forms?
FH types I to IE. They're autosomal dominant, meaning a 50% chance of passing it on. Type I, or glucocorticoid-remediable aldosteronism, GRA, is unique. It's caused by a gene fusion that puts aldosterone production under ACTH control.
So cortisol-blocking drugs would lower aldosterone?
Exactly. Small doses of glucocorticoids suppress ACTH and normalize aldosterone and blood pressure. It often presents earlier, maybe in the 20s, and potassium might be normal. The other FH types involve different gene mutations and are generally managed like sporadic PA, requiring careful workup and genetic counseling.
Clinically, besides high blood pressure, what symptoms might someone have?
If the potassium level drops significantly, hypokalemia, which happens variably, patients might feel muscle weakness, cramps, or fatigue. Some might get palpitations, especially if given diuretics, but often patients are asymptomatic apart from the hypertension, which is why screening specific groups is so important.
Which groups should be screened?
The guidelines generally recommend screening patients with drug-resistant hypertension, hypertension diagnosed young, 40, severe hypertension, hypertension with an adrenal incidentalloma, hypertension with sleep apnea, or those with a family history of early onset hypertension or stroke, or PA itself.
Diagnosis hinges on those biochemical tests again.
Yes. First, you suspect it maybe from routine labs showing low potassium, though many are normokalemic. The key is demonstrating inappropriate aldosterone production despite salt loading or renin suppression. The screening test is the aldosterone-renin ratio, ARR. You need a high aldosterone level and a suppressed plasma renin activity. A very high ARR is strongly suggestive.
And the medication issue is critical here, too.
Absolutely crucial. Many common blood pressure medications, especially those acting on the renin-angiotensin system, like ACE inhibitors, ARBs, diuretics, beta blockers, and even mineralocorticoid receptor antagonists themselves, spironolactone, eplerenone, interfere with the tests. They must be stopped for an appropriate period, often 2 to 4 weeks, depending on the drug before testing, usually substituting with drugs that have minimal effect, like alpha blockers or certain calcium channel blockers.
Okay, biochemical diagnosis confirmed. Now, the crucial step, unilateral versus bilateral, imaging first.
Yes. High-resolution adrenal CT, thin slices, 2-3 millimeter, is the initial imaging test. APAs typically appear as small, 1-2 centimeter, low-density 10 HU nodules. BAH might show diffusely enlarged or nodular glands, or sometimes look entirely normal.
But the source says CT alone isn't always reliable for lateralization.
That's a really important point.
Yeah.
Especially in patients over 35 or 40, small, non-functioning adrenal nodules unrelated to the PA become quite common. So seeing a nodule on CT doesn't automatically mean it's the source of the aldosterone. You could mistakenly operate on someone with bilateral disease who happens to have a coincidental nodule.
Or miss a small APA if the glands look generally normal on CT.
Exactly. That's why adrenal vein sampling, AVS, is considered the gold standard procedure to definitively determine if the aldosterone excess is coming from one side or both.
How does AVS work?
It's an interventional radiology procedure where thin catheters are carefully threaded into the veins, draining each adrenal gland. Blood samples are taken simultaneously from both adrenal veins and a peripheral vein. By comparing the aldosterone levels, usually relative to cortisol to confirm correct catheter placement, you can determine if one gland is secreting much more aldosterone than the other.
That's technically challenging.
It is, and requires significant expertise to perform accurately and safely. Success rates depend heavily on the operator's experience. Because of this, it's typically reserved for patients where the distinction between unilateral and bilateral disease will change management, usually those over 35-40, or those with unclear or bilateral findings on CT. In younger patients, 35, with classic biochemical findings and a clear unilateral adenoma on CT, surgery based on CT might be considered reasonable by some centers.
What if AVS is impossible or the results are unclear?
The source mentions 11C metomidate PE scanning as an emerging technique that shows promise for lateralization in those difficult cases. It targets enzymes involved in steroid synthesis.
Okay, so you've lateralized the source. How does treatment proceed?
If AVS, or confident CT in a young patient, confirms unilateral secretion, typically from an APA, then minimally invasive laparoscopic adrenalectomy is the treatment of choice.
And the outcomes are good.
Generally excellent. Surgery cures the hyperaldosteronism biochemically. Hypertension is often cured or significantly improved, reducing or eliminating medication needs in most patients. Hypokalemia resolves. Preoperative medical control of blood pressure and potassium with drugs like spironolactone is crucial for safety during surgery.
What about bilateral disease, BAH?
That's managed medically, long-term. The cornerstone drugs are mineralocorticoid receptor antagonist spironolactone or eplerenone, which block aldosterone's effects. Other antihypertensives are usually needed as well. Surgery isn't typically indicated unless there's a very large, suspicious dominant nodule.
And the familial types?
Managed by specialists, often medically, especially FH type I. Surgery only if a clear unilateral source is identified despite the genetic predisposition.
Okay, let's transition to the opposite end of the HPA axis regulation. In a way, Cushing syndrome, or hypercortisolism.
Right. This is the clinical state resulting from prolonged exposure to excess cortisol. It can be caused by too much ACTH driving the adrenals, or the adrenals producing cortisol autonomously.
What are the sources of excess ACTH?
The most common endogenous cause overall is a pituitary adenoma secreting ACTH that's specifically called Cushing's disease, accounting for 70-80% of ACTH-dependent cases. Less commonly, a non-pituitary tumor somewhere else in the body, like the lung or pancreas, can ectopically produce ACTH.
And the adrenal causes?
These are ACTH independent, meaning the adrenals are overproducing cortisol on their own, suppressing pituitary ACTH. This accounts for about 10-15% of endogenous Cushing's. The usual culprit is a benign cortisol-producing adrenal adenoma. Less often, it's bilateral adrenal nodular hyperplasia, or rarely an adrenocortical carcinoma.
We should also mention the most common cause overall, right?
Absolutely. Exogenous glucocorticoid medication is by far the most prevalent cause of Cushingoid features. Always need to rule that out first. But we're focusing on the endogenous causes needing diagnosis and specific treatment.
And untreated endogenous Cushing's is serious.
Very. The source mentions a 5-fold increased risk of cardiovascular death, plus risks of diabetes, infections, osteoporosis, psychiatric issues. The goal is to normalize cortisol levels by treating the underlying cause, ideally without causing permanent adrenal insufficiency.
Clinically, we touched on the widespread effects of cortisol. Can you recap the key features?
It's a constellation of symptoms and signs. Think weight gain, especially central, abdomen, face, neck, moon face, buffalo hump. Thinning skin, easy bruising, prominent purple stretch marks, striae. Muscle weakness, particularly proximal, difficulty getting up from a chair. High blood pressure, high blood sugar, or diabetes. Bone loss, osteoporosis. Increased susceptibility to infections. Mood changes, depression, anxiety, irritability. In women, irregular periods and excess hair growth. Hirsutism. It's a very characteristic, though sometimes subtle, picture.
But subclinical Cushing's exists too. Hormonal excess without the obvious signs.
Yes, particularly relevant when investigating adrenal incidentalomas. Patients might just have mild hypertension, borderline diabetes, or osteoporosis that doesn't seem fully explained. Biochemical testing is key.
So how do you diagnose it biochemically?
First, confirm hypercortisolism. The Endocrine Society guidelines recommend using at least 2 different first-line tests to be sure, because no single test is perfect. The main ones are 1. Late-night salivary cortisol, measures cortisol when it should be lowest, loss of diurnal rhythm. 2. 24-hour urinary-free cortisol, UFC. Measures cortisol excretion over a full day, catches overspill, needs to be significantly elevated, Irigi 3x upper limit. 3. 1 milligram overnight dexamethasone suppression test, ODST. Give dexamethasone at night, check cortisol next morning. Failure to suppress cortisol below a certain threshold, for example, 50 ovumore or 1.8 millicgl, is abnormal.
Once hypercortisolism is confirmed, you need to figure out why ACTH dependent or independent.
Exactly. The next step is measuring plasma ACTH levels, ideally early morning. If ACTH is normal or high, it suggests an ACTH-dependent cause, pituitary or ectopic. If ACTH is suppressed, very low, even 5 pg/ml, it points strongly towards an adrenal source autonomously producing cortisol.
And that ACTH result dictates the next steps in imaging.
Precisely. If ACTH is elevated, ACTH-dependent, you suspect pituitary source first. So pituitary MRI is usually the next step. If the MRI is negative or inconclusive, or if clinical suspicion for ectopic is high, further tests like inferior petrosal sinus sampling, IPSS, to confirm pituitary origin, or imaging to search for an ectopic tumor, CT, chest, abdomen, pelvis, maybe functional imaging like 68G, SSTR, PTCT are needed.
And if ACTH is suppressed, ACTH independent.
Then the problem lies within the adrenal glands. You need dedicated adrenal imaging, high-resolution CT or MRI to look for a unilateral adrenal adenoma, bilateral hyperplasia, or the rarer adrenocortical carcinoma. Benign cortisol-producing adenomas usually look similar to non-functioning adenomas on imaging. Small, well-defined, often lipid-rich low density.
Treatment then depends entirely on identifying the underlying cause.
Absolutely. For Cushing's disease, pituitary adenoma, transsphenoidal surgery to remove the pituitary tumor is the primary treatment, sometimes followed by radiation. For ectopic ACTH syndrome, resecting the ACTH-producing tumor, if possible, is curative, if the ACTH source can't be found or removed, or if pituitary surgery fails. Bilateral adrenalectomy might be considered to control the severe hypercortisolism, but this renders the patient permanently steroid dependent.
And for the adrenal causes?
For a unilateral cortisol-producing adrenal adenoma, minimally invasive laparoscopic adrenalectomy is the standard curative treatment unless ACC is suspected. For bilateral ACTH-independent adrenal disease, like bilateral macronodular hyperplasia, management is complex. Bilateral adrenalectomy provides definitive control but causes steroid dependence. If the disease is very asymmetric, removing just the larger, more active gland might sometimes be sufficient. For subclinical Cushing's from a unilateral adenoma, surgery is generally recommended if the tumor is large, 4 centimeters, or if the patient has related metabolic issues, diabetes, hypertension, osteoporosis, even with smaller tumors.
The source emphasizes careful preoperative management for Cushing's patients undergoing surgery. Why?
Because chronic cortisol excess makes patients frail and high risk. They have increased risk of blood clots, VTE, poor wound healing, infections, cardiovascular events, and poorly controlled diabetes. So meticulous VTE prophylaxis, chemical and mechanical, perioperative antibiotics, and tight glucose control are essential.
And the steroid management around surgery is critical.
Absolutely. Removing the source of excess cortisol, whether it's the pituitary tumor, ectopic source, or the adrenal tumor itself, leads to a sudden drop in cortisol levels. Patients who've had chronic suppression of their normal HPA axis, or who have had one or both adrenals removed, will develop acute adrenal insufficiency if not given replacement steroids. So perioperative intravenous hydrocortisone cover is mandatory, followed by oral replacement requiring close endocrinology input.
Postoperatively, what's the recovery like?
After removing a unilateral adrenal adenoma, the patient's other adrenal gland has been suppressed by the excess cortisol and may take weeks, months, or even up to a year to recover normal function. During this time, the patient needs physiological hydrocortisone replacement therapy, which is gradually tapered down based on clinical assessment and periodic testing, like the synacthin test, to check for recovery of the remaining gland.
What about after bilateral adrenalectomy?
They require a lifelong glucocorticoid and usually mineralocorticoid replacement. Also, if bilateral adrenalectomy was done for Cushing's disease, uncontrolled pituitary ACTH, about 10% develop Nelson's syndrome. Later, the pituitary ACTH-producing tumor grows aggressively without the feedback from adrenal cortisol, causing very high ACTH levels and skin hyperpigmentation.
Okay, let's move to a more sinister adrenal cortex disorder, adrenocortical carcinoma, ACC.
Yeah, ACC is a rare but highly aggressive malignancy. The source highlights its variable, often poor prognosis, frequently due to late diagnosis when the disease is already advanced.
Incidence?
Very low, about 1 to 2 cases per million people per year. There's a slight female predominance, and it tends to peak in the 4th and 5th decades of life.
Pathologically, how does it look?
ACCs are often large at diagnosis, frequently greater than 10 centimeters. They tend to look heterogeneous, orange-brown, often with areas of necrosis or haemorrhage, figure 57.7. Distinguishing a malignant ACC from a benign adenoma based purely on histology can be difficult unless there's obvious invasion into surrounding tissues or distant metastases.
Are there pathological scoring systems?
Yes. The source mentions the modified Weiss histopathological system. It assesses features like mitotic rate, presence of atypical mitosis, necrosis, clear cell percentage, and capsular vascular invasion. A score of 3 or more suggests malignancy. The Chi-67 proliferation index is also important. A higher percentage of staining indicates faster growth and generally a poorer prognosis.
How do patients typically present?
It's variable. About 50–60% present due to symptoms of hormone excess, most commonly Cushing's syndrome, or sometimes a mixed picture of Cushing's and virilization, excess androgens causing masculine features in women. About 30–40% present with symptoms related to the tumor mass itself, like abdominal or flank pain or feeling a lump, and perhaps a sixth are discovered incidentally. Pure mineralocorticoid excess or feminization in men are rare presentations.
Diagnosis relies heavily on imaging, but biochemical workup is still essential.
Absolutely critical. While a CT or MRI often strongly suggest ACC due to size, 6 centimeters usually, heterogeneity, irregular margins, necrosis, or evidence of local invasion or metastasis, figure 57.8, you must do the biochemical evaluations.
Why?
Firstly, to characterize any hormone excess, which helps confirm adrenal origin and guides perioperative management. For example, steroid cover for cortisol excess. You check for cortisol excess, low-dose DEX suppression test, adrenal androgens, DHEAS, testosterone, and potentially estradiol. Secondly, and crucially, you must exclude a coexisting or mimicking phaeochromocytoma by measuring plasma or urinary metanephrines before any biopsy or surgery. Operating on an unsuspected pheo can be catastrophic.
And staging is important.
Yeah, staging involves CT of the chest, abdomen, and pelvis to look for metastases, commonly in the lungs and liver. FDG-PET scans can be complementary to detect occult metastatic disease.
The source strongly discourages routine adrenal biopsy for suspected ACC.
That's right. Fine needle aspiration, FNA cytology, generally cannot reliably distinguish benign from malignant primary adrenal tumors. There's also a theoretical risk of seeding tumor cells along the needle track. Biopsy is usually reserved only for confirming metastatic disease in patients with widespread cancer, where the primary site is uncertain, or to guide palliative systemic therapy choices.
So the primary treatment for potentially localized ACC is surgery.
Yes. Complete surgical resection, an R0 resection meaning no microscopic tumor left behind, offers the only potential for cure. This requires an experienced surgical team, often involving an open radical adrenalectomy.
Laparoscopy is generally not recommended.
For suspected ACC, especially if large, 6 centimeters, are showing signs of invasion, open surgery is mandated. The goal is often an en bloc resection, meaning removing the tumor along with any adherent or invaded adjacent structures, like part of the kidney, spleen, pancreas, or diaphragm, to achieve clear margins. This needs careful preoperative planning and patient consent.
What about if there's already metastatic disease at diagnosis?
Management is complex and requires MDT discussion. If METs are limited, for example, only a few resectable liver mets, some centers advocate aggressive surgery to remove the primary tumor and the metastases. For widespread metastatic disease, initial surgery is not usually the first step. Systemic therapy is often started first.
What systemic therapies are used?
Mitotane is the mainstay adjuvant therapy for patients at high risk of recurrence after surgery. AgiG, large tumor, high Ki-67, positive margins, rupture, and is the primary medical treatment for metastatic ACC. It's an adrenalytic drug, toxic to adrenocortical cells, and can improve disease-free and overall survival. It's often given for several years. Patients on mitotane usually require hydrocortisone replacement because it affects normal adrenal function too. If mitotane fails or isn't tolerated, cytotoxic chemotherapy, like the EDP regimen, is used.
And prognosis?
Still challenging and strongly dependent on the stage at diagnosis. The source quotes 5-year disease-specific survival rates from the ENS8 classification. Stage 1, 82%, Stage 2, 61%, Stage 3, 50%, but Stage 4, distant mets, only around 13%. Early detection and complete resection are key.
Briefly, what about metastases to the adrenal gland from other cancers?
Adrenomets aren't uncommon, often from lung, kidney, melanoma, breast, or colorectal cancer. They often indicate disseminated disease. Management depends on whether the adrenal met is truly isolated or part of widespread disease.
How's that determined?
Requires thorough staging, usually including CT chest, abdomen, pelvis, and often PT-CT. You also need to biochemically screen for adrenal hormone excess, just in case it's a coincidental functioning tumor. If widespread disease, systemic therapy for the primary cancer is the main approach. If the adrenal met appears isolated, especially if it appears metachronically long after the primary was treated, surgical resection, adrenalectomy, might be considered, often after a period of observation to ensure no other mets appear. Laparoscopic adrenalectomy is preferred if feasible. Survival benefit is most established for isolated mets from renal cell cancer and possibly lung cancer.
Let's touch on a couple of other adrenal cortex conditions. Congenital adrenal hyperplasia, CAH.
This is a group of inherited autosomal recessive disorders caused by enzyme defects in the cortisol synthesis pathway. The most common form, 95%, is 21-hydroxylase deficiency.
What's the consequence?
The block in cortisol production leads to a loss of negative feedback, so the pituitary cranks out excess ACTH. This ACTH then overstimulates the adrenal cortex, but because the cortisol pathway is blocked, the precursors get shunted into the androgen production pathway,
leading to
excess androgens. In baby girls, this can cause ambiguous genitalia at birth. Later onset forms can cause virilization in females at puberty, premature puberty, short stature due to early epiphyseal plate closure, and hypertension in some types. Patients are also at risk of adrenal insufficiency, especially during stress.
Right.
Lifelong hormone replacement with glucocorticoids like hydrocortisone to replace cortisol and suppress ACTH, and often mineralocorticoids, fludrocortisone if aldosterone production is also affected. Surgery is rarely needed, perhaps for very large hyperplastic glands causing symptoms.
Adrenal insufficiency when the adrenals don't produce enough hormones.
Right. It can be primary, Addison's disease, where the adrenal cortex itself is destroyed, often autoimmune, sometimes infection like TB. Or it can be secondary, pituitary not making ACTH, or tertiary, hypothalamus not making CRH.
What's the key difference between primary and secondary tertiary?
In primary adrenal insufficiency, both glucocorticoid, cortisol, and mineralocorticoid, aldosterone production are usually lost. In secondary tertiary, ACTH is deficient, so cortisol production fails, but aldosterone production, mainly controlled by renin-angiotensin, is typically spared.
Acute adrenal insufficiency, the Addisonian crisis, sounds serious.
It's a true medical emergency. Presentation is often nonspecific. Shock, low blood pressure, fever, nausea, vomiting, abdominal pain, confusion, low blood sugar, electrolyte imbalances, low sodium hypotassium in primary AI. It can be rapidly fatal if not recognized and treated immediately, often precipitated by illness, injury, or surgery in someone with underlying, maybe undiagnosed AI.
How does chronic adrenal insufficiency present?
Usually more insidiously. Fatigue, weakness, weight loss, poor appetite, and nausea. Hyperpigmentation, darkening of skin, especially creases and gums, is characteristic of primary AI due to high ACTH levels. POMC precursor yields both ACTH and MSH. Low blood pressure, salt craving, low sodium hypotassium, low blood sugar can occur, particularly in primary AI due to mineralocorticoid deficiency.
Diagnosis.
You need to demonstrate low cortisol production. The key test is the ACTH stimulation test, synactin test. You measure baseline cortisol, give synthetic ACTH, and measure cortisol again after 30-60 minutes. A failure of cortisol to rise adequately confirms adrenal insufficiency. Measuring baseline ACTH helps distinguish primary, high ACTH, from secondary tertiary, low normal ACTH.
Okay.
Acute crisis. Don't wait for tests. Treat immediately with intravenous fluids, saline, and high-dose intravenous hydrocortisone. For example, 100 milligram bolus, then infusion or hourly injections. Monitor closely, treat underlying cause, for example, infection. Taper steroids as patient improves. Chronic AI, lifelong hormone replacement. Oral hydrocortisone, usually 15-25 milligrams daily, split into 2-3 doses mimicking diurnal rhythm, replaces cortisol. Oral fludrocortisone, usually 0.05-0.2 milligram daily, replaces aldosterone in primary AI. Patient education is crucial. They need to know how to increase their steroid dose during illness, sick day rules, and require extra cover for surgery or major procedures. Medical alert bracelets are recommended.
One last adrenal condition mentioned, adrenal hemorrhage.
Yes, bleeding into the adrenal glands can be serious, potentially leading to acute adrenal insufficiency if bilateral shock or even death. The adrenals are very vascular.
What triggers it?
Often associated with severe stress like sepsis, major trauma or surgery, heart attack. Also linked to anticoagulation therapy and conditions like antiphospholipid syndrome, sometimes happen spontaneously.
Presentation and diagnosis.
Can be nonspecific abdominal or flank pain or present dramatically with shock or signs of acute AI. CT scan is usually how it's diagnosed, showing an enlarged adrenal gland filled with blood. Figure 57.9a.
Management.
Mostly conservative. Supportive care, monitor vital signs and electrolytes, check adrenal function, ACTH stim test if suspected AI, especially if bilateral. Stop anticoagulants temporarily if possible. Rarely, if bleeding is massive and ongoing, interventional radiology might be needed for embolization. Figure 57.9b. If bilateral hemorrhage occurs, lifelong steroid replacement may be necessary.
That's a thorough tour of adrenal cortex and medulla disorders. Now let's talk specifically about the surgery itself. We know laparoscopic is preferred, but what are the main approaches?
The two dominant, minimally invasive techniques are the transperitoneal laparoscopic approach and the posterior retroperitoneoscopic approach.
Let's start with transperitoneal, through the belly.
Yes. The surgeon enters the main abdominal cavity. The setup and steps differ slightly for the right versus the left side because of the anatomy we discussed.
How does it work on the right?
The patient is positioned with the right side up. Typically, 4 small incisions, ports, are made. The liver needs to be retracted upwards. The surgeon opens the peritoneum along the IVC to expose the adrenal gland. The key early step is carefully identifying and controlling the short right adrenal vein where it enters the IVC, usually clipped and depleted. Then the gland is dissected free from the kidney, diaphragm, and liver.
Again on the left.
Patient positioned left side up, usually 3 ports. The surgeon needs to mobilize the spleen, the tail of the pancreas, and the splenic flexure of the colon inwards, medial visceral rotation, to get access to the retroperitoneal space where the left adrenal sits. The left adrenal vein draining into the renal vein is identified, clipped, and divided. Then the gland is dissected free from its attachments. The main advantage of the transperitoneal approach is the familiar anatomy for most general laparoscopic surgeons and potentially a larger working space for bigger tumors.
What about the posterior retroperitoneoscopic approach, from the back?
Correct. This avoids entering the abdominal cavity altogether. The patient lies prone, face down. Cords are placed below the 12th rib. The surgeon creates a space directly in the retroperitoneum, behind the kidney's fascia, toroides. The adrenal gland is found superior to the kidney. The dissection proceeds to identify and ligate the adrenal vein, right near IVC, left near renal vein.
What are the advantages of this posterior approach?
It can be quicker, especially for bilateral adrenalectomies, as you don't need to drastically reposition the patient between sides. It's also excellent for patients who have had previous extensive abdominal surgery with lots of scar tissue, or in some cases of obesity. The dissection planes can be very clean.
Are there limitations?
It can be more challenging for very large tumors, say bigger than 5 or 6 centimeters, as the working space is more confined. Some surgeons find it technically more demanding initially if they're not used to the retroperitoneal view. Severe obesity, BMI 40, can also make it difficult.
When is open adrenalectomy still the way to go?
Primarily when dealing with suspected or confirmed adrenocortical carcinoma, ACC, where a wide oncologically sound resection with clear margins is paramount. Also for very large benign tumors, perhaps over 8-10 centimeters, where laparoscopic removal might be difficult or unsafe.
And the goal for ACC surgery is?
An R0 en-bloc resection. That means removing the tumor with a clear margin of normal tissue around it, potentially including parts of adjacent organs if they are invaded. kidney, spleen, pancreas, diaphragm, liver. This requires a larger incision, like a rooftop or subcostal incision, careful dissection around major vessels, and meticulous technique. Patients need to be consented for potentially extensive surgery.
What are the general outcomes of adrenal surgery?
Mortality is very low for benign disease, less than 0.5% according to the source. It's higher for malignant tumors due to the nature of the disease and the extent of surgery. The source also briefly mentions subtotal adrenalectomy, removing only part of the gland as a potential option for small bilateral tumors, like in MN syndromes, to try and preserve some adrenal function and avoid lifelong steroid dependence. But this is not standard practice and carries a risk of recurrence. Ultimately, excellent outcomes rely on performing the right operation for the right patient, careful preoperative preparation, experienced surgical and anesthetic teams, and close collaboration with endocrinologists for managing hormone levels before and after surgery.
Okay, fantastic overview of the surgical techniques. Now let's shift focus slightly back to specific tumor types, particularly those arising from the neuroendocrine cells we discussed earlier, phaeochromocytoma, PCC, and paraganglioma, PGL, collectively called PPGLs.
Right. Just to recap, PCCs arise from the chromaffin cells within the adrenal medulla. PGLs arise from similar cells in the extraadrenal paraganglia, which can be sympathetic, usually along the aorta or sympathetic chain, often secrete catecholamines, or parasympathetic, often in the head neck near cranial nerves, usually non-secreting.
They're rare, but have a strong genetic component.
Yes. While most PCCs are sporadic, about 75%, overall about 30% or more of all PPGLs are linked to inherited germline mutations in specific susceptibility genes. The source mentions several key ones. Subunits of the succinate dehydrogenase enzyme complex, SDHA, SDHB, SDHC, SDHB-MMX, TMM127. There are also features of syndromes like von Hippel-Lindau, VHL, neurofibromatosis type 1, NF1, and multiple endocrine neoplasia type 2, MN2.
Do specific genes predict behavior?
There's a strong correlation. For example, mutations in SDHB are particularly associated with a high risk of the PGL being malignant, meaning it metastasizes. The source quotes risks as high as 34-97%. SDHD mutations often cause multiple head and neck PGLs, but they have a lower risk of malignancy. Knowing the underlying genetic mutation helps guide management, surveillance for other tumors, and family screening.
Pathologically, PCCs look distinctive.
They're often described as gray-pink, highly vascular tumors, frequently showing areas of hemorrhage or necrosis. But similar to ACC, reliably distinguishing benign from malignant PPGL based purely on the primary tumor's histology is very difficult. Malignancy is defined by the presence of metastases in sites where chromaffin tissue isn't normally found, like lymph nodes, bone, liver, lung. Features like large size, invasion, high mitotic rate using scoring systems like PASS, or high Chi67 can suggest a higher risk of malignant behavior but aren't definitive.
And clinically, the functioning tumors present with symptoms of catecholamine excess.
Yes, the classic symptoms result from surges of adrenaline and noradrenaline. The source lists the common ones, table 57.3. Hypertension is very common, 80 to 90%, but can be sustained or episodic, paroxysmal. The classic triad is severe headache, profuse sweating, and palpitations occurring during these episodes. Pallor, not flushing, anxiety, tremor, nausea, weight loss, and high blood sugar can also occur.
These episodes can be triggered.
Yes, often by physical exertion, stress, certain foods, tyramine-rich, anesthesia induction, or medications like contrast dye, some antidepressants, or metoclopramide. Unrecognized PCGL is a major hazard during any surgery or procedure. Head and neck PGLs, being often non-secreting, might present as a neck mass or with symptoms due to nerve compression, hoarseness, swallowing difficulty, tinnitus.
Diagnosis relies first on biochemical confirmation.
Absolutely. You need to prove excess catecholamine production. The best tests are measurements of metanephrines. Metanephrine and norepinephrine, the metabolites of adrenaline and noradrenaline, in either plasma or a 24-hour urine collection. These are more sensitive, around 99% for plasma, 97% for urine, than measuring the parent catecholamines themselves. Because secretion can be episodic, but metabolism is more continuous within the tumor.
How high do the levels need to be?
Markedly elevated levels, typically more than 4 times the upper limit of the reference range, are considered virtually diagnostic. Plasma dopamine levels might be elevated in malignant PPGL and can be a marker of tumor burden.
Once confirmed biochemically, then you localize.
Yes. CT or MRI of the abdomen and pelvis is usually the first step to find the tumor, assess its size, and look for features suggesting malignancy, invasion nodes. figure 57.2. Unlike ACC, size itself isn't a reliable predictor of malignancy for PCC.
What if the abdominal scan is negative or you suspect PGLs elsewhere?
Then functional imaging is needed. 123I Avid G scintigraphy has traditionally been used. It's taken up by chromaffin cells, 80-90% sensitive. Somatostatin receptor imaging, like 111 octreotide or ideally 68 dotatate PET-CT, can also be useful, especially for head neck PGLs and some metastatic disease, figure 57.11. Newer P-tracers like 18F-FDOPA are also very sensitive, particularly for PGLs.
Okay, tumor found. What's the crucial step before surgery?
Medical preparation to block the effects of the excess catecholamines. This is non-negotiable to prevent life-threatening hypertensive crises and arrhythmias during anesthesia and surgery.
How's that done?
The classic approach involves starting an irreversible alpha adrenoceptor blocker, like phenoxybenzamine, several days to weeks before surgery. The dose is gradually increased until the patient reports mild postural hypotension, dizziness on standing, indicating adequate blockade. Only after achieving good alpha blockade should a beta blocker be added, if needed, to control tachycardia. Starting a beta blocker first is dangerous, as it can lead to unopposed alpha stimulation and severe hypertension. Other regimens using selective alpha blockers, doxosin, prazosin, or calcium channel blockers exist, but the principle is the same. Block alpha receptors thoroughly first. This preparation has dramatically reduced surgical mortality. Anesthesia requires experienced providers, invasive monitoring, arterial line, central line, and readiness to manage rapid blood pressure swings, especially the potential drop when the tumor's vein is ligated.
Surgical treatment is then excision?
Yes. Complete removal of the PPGL is the goal. For most PCCs, laparoscopic adrenalectomy is the standard approach unless the tumor is very large, 10 centimeters, or has clear signs of malignancy on imaging, in which case open surgery might be preferred.
What about surgery for PGLs outside the adrenal?
That can be technically more demanding depending on the location, resembling near major vessels like the aorta or vena cava, or in the head neck. Hereditary PGLs also have a higher risk of recurrence. Minimally invasive approaches may not always be feasible, and open surgery is often necessary.
What about malignant PPGL?
Surgery still offers the best chance for cure if the disease is localized, aiming for R0 resection. If there's direct invasion, open en-bloc resection is needed. Even in the presence of metastases, removing the primary tumor is often recommended to reduce hormone load and potentially improve the efficacy of other treatments, like radionuclide therapy or chemotherapy. However, the prognosis for metastatic TPGL is guarded, with 5-year survival often less than 50%.
And PPGL in pregnancy?
A rare but very dangerous situation if undiagnosed, potentially mimicking severe preeclampsia. Requires careful alpha blockade. If diagnosed early, for second trimester, laparoscopic adrenalectomy after blockade might be considered, though carries risks. If diagnosed in the third trimester, treatment usually involves blockade followed by elective C-section with adrenalectomy performed postpartum. Undiagnosed maternal mortality can be as high as 50%.
Let's briefly cover 2 other neuroendocrine tumors mentioned, neuroblastoma and ganglioneuroma.
Neuroblastoma, and B, is actually the most common solid cancer outside the brain in children and can be very aggressive. It arises from primitive neuroblasts of the sympathetic nervous system derived from the neural crest. About 40% originate in the adrenal medulla.
It's described as a clinical enigma.
Yes, because its behavior is incredibly variable. Some tumors, especially in infants, can spontaneously regress, while others are highly resistant to treatment and rapidly fatal. Diagnosis involves imaging, CT-MRI, MEG scan figure 57.31, urine catecholamine metabolites, often elevated, and biopsy for histology and crucial genetic markers, like MYCN amplification, a strong predictor of poor prognosis. Treatment depends heavily on age and risk stratification, low, intermediate, high risk, involving surgery, chemotherapy, and sometimes radiation or immunotherapy.
And ganglioneuroma.
GNM. This is the benign, fully differentiated counterpart to neuroblastoma arising from mature autonomic ganglion cells. It's rare, often found incidentally, usually in adolescents or young adults. Common locations include the posterior mediastinum, retroperitoneum, and adrenal medulla, 30%. They are typically non-secreting and slow-growing, presenting due to mass effect if large. Treatment is surgical excision, usually curative with excellent prognosis. Laparoscopic removal is preferred if feasible.
All right, we've covered the adrenals extensively. Let's move now into the broader diffuse neuroendocrine system within the abdomen, focusing on pancreatic and gastrointestinal neuroendocrine tumors, often abbreviated as PNETs and GINETs.
Yes, these arise from those scattered neuroendocrine cells throughout the pancreas and the lining of the GI tract, originating embryologically from the foregut, midgut, or hindgut.
We mentioned these cells produce markers like chromogranin A.
Right, chromogranin A is a protein stored and released along with hormones from these cells, so it can be elevated in the blood and serve as a general tumor marker, though it's not specific. Synaptophysin is another common marker seen on pathology. For certain tumors, specific hormone measurements are key, like urinary 5-HIAA, a serotonin metabolite, for midgut nets associated with carcinoid syndrome.
GI nets used to be called carcinoids. Why the change?
Carcinoid was coined by Oberndorfer to describe tumors that looked carcinoma-like but seemed less aggressive. However, we now know these are a very diverse group of tumors, ranging from benign to highly malignant. The modern WHO classification emphasizes the site of origin, pancreas, stomach, small intestine, etc., and crucially, the tumor's grade, based on its proliferation rate, Chi-67 index, and mitotic count table 57.5. This grading is essential for predicting behavior and guiding treatment.
What's the mechanism behind carcinoid syndrome?
This classic syndrome is typically associated with nets arising in the midgut, small intestine appendix. These tumors often produce large amounts of serotonin, 5-HT. Normally, serotonin released into the portal vein, draining the gut, is metabolized and inactivated by the liver. However, once the tumor metastasizes to the liver, the serotonin and other active substances produced by the liver mets bypasses this first-pass metabolism and enters the systemic circulation via the hepatic veins and IVC.
And that systemic serotonin causes the symptoms.
Yes, the cardinal features are flushing, often episodic, red violaceous, secretory diarrhea, wheezing or bronchospasm, and eventually, potentially, carcinoid heart disease fibrosis, predominantly affecting the right-sided heart valves, tricuspid and pulmonary, leading to regurgitation and heart failure, Hettinger syndrome.
Are nets common?
They are considered rare overall, but their incidence seems to be increasing, possibly due to better detection. The source quotes an overall incidence of 2.5.5 per 100,000 per year, but a higher prevalence, around 35 per 100,000, because patients often live with the disease for a long time due to its often indolent nature. The distribution varies, with the appendix and small bowel being common sites historically, though detection in pancreas, stomach, and rectum is increasing, table 57.6.
Let's focus first on pancreatic neuroendocrine tumors, PNETs. These arise from the islet cells.
Correct, from the neuroendocrine cells within the pancreatic islets of Langerhans. These islets make up only 1 to 2% of the pancreas mass, but contain several cell types crucial for glucose homeostasis. Beta cells, making insulin 65-80%, alpha cells, glucagon 15-20%, delta cells, somatostatin 3-10%, and PP cells, pancreatic polypeptide 1%.
PNETs can be functional, producing excess hormones, or non-functional. Let's start with a classic functional one, insulinoma.
This is a tumor of the pancreatic beta cells, producing excess insulin inappropriately, leading to hypoglycemia, low blood sugar. It's rare, maybe 4 cases per million per year.
What are the symptoms?
They stem from the low blood sugar. 2 categories. 1, neurolycopenic symptoms, due to the brain being starved of glucose, confusion, blurred vision, abnormal behavior, seizures, loss of consciousness, coma. 2, autonomic counter-regulatory symptoms, the body's response to low sugar sweating, weakness, intense hunger, tremor, anxiety, palpitations. 2, autonomic counter-regulatory symptoms. These symptoms classically occur during fasting or after exercise. Diagnosis can be delayed as symptoms might be mistaken for neurological or psychiatric issues. Patients often gain weight because they learn to eat frequently to avoid symptoms.
How is it definitively diagnosed?
The cornerstone is the supervised 72-hour fast. During the fast, you look for the documentation of Whipple's triad: 1, symptoms of hypoglycemia; 2, documented low plasma glucose, 3.0 millimolar or 55 milligdl at the time of symptoms; and 3, relief of symptoms after glucose administration. Crucially, during the hypoglycemic episode, you must draw blood to show inappropriately high levels of insulin, C-peptide, a marker of endogenous insulin production, and proinsulin, confirming endogenous hyperinsulinism.
Are there mimics?
Yes, need to exclude things like factitious hypoglycemia, surreptitious insulin or sulfonylurea use. C-peptide would be low if exogenous insulin is used. Dumping syndrome after gastric surgery, or rare conditions like nocidioblastosis, diffuse islet cell hyperplasia, mainly in infants.
Once confirmed biochemically, you need to find the tumor. Are they easy to locate?
Often not. Insulinomas are typically small, 2 centimeters, benign, 90%, and solitary, scattered throughout the pancreas. High-resolution CT or MRI might miss up to 10-30%. Endoscopic ultrasound, EUS, is highly sensitive, detecting over 90%. If these are negative, more invasive tests like selective arterial calcium stimulation with hepatic venous sampling, or potentially newer PET scans like 11C GLP-1 PET might be considered. About 10% occur in the context of N1 syndrome, where they can be multiple. Primarily surgical cure. Medical therapy like diazoxide can suppress insulin secretion preoperatively or palliate symptoms in unresectable cases. For localized sporadic insulinomas, surgical enucleation, scooping out just the tumor, is often possible, preserving pancreatic tissue. This is preferably done laparoscopically. Blind pancreatic resections are not recommended if the tumor cannot be localized. For MEN1-associated insulinomas, management is more complex due to multiplicity.
Okay, next functional PNET. Gastronoma, causing Zollinger-Ellison syndrome, ZES.
This is a tumor producing excess gastrin, a hormone that powerfully stimulates stomach acid production. The result is severe, often multiple, recurrent, or unusually located peptic ulcers, and frequently diarrhea, due to the large volume of acid overwhelming digestive processes.
Incidence and location.
Even rarer than insulinoma, maybe 0.54 cases per million per year, accounts for only about 0.1% of duodenal ulcers. About 20–25% are associated with MEN1. Sporadic gastrinomas are most commonly found in the duodenum, 60–80%, often very small, 5 millimeters, and sometimes multiple. Interestingly, in MEN1, virtually all gastrinomas arise in the duodenum. The vast majority, 90% of all gastrinomas, occur within the gastronoma triangle, an anatomical region bounded by the junction of the cystic and common bile ducts, the junction of the second and third parts of the duodenum, and the junction of the pancreatic neck and body. Figure 57.15.
Malignant potential.
Gastrinomas are often malignant, meaning they can metastasize, particularly to lymph nodes and the liver. However, they are often slow-growing. The source quotes 5-year survival around 65%, 10-year around 51%. Complete surgical resection, if possible, offers excellent long-term survival, 90–100%. Pancreatic primary location generally carries a worse prognosis than duodenal.
Diagnosis.
Suspect ZES in patients with severe or refractory ulcer disease, ulcers in unusual locations, or ulcers plus diarrhea. The diagnostic cornerstone is demonstrating a markedly elevated fasting serum gastrin, FSG level. However, the most common cause of elevated gastrin is not ZES, but rather reduced stomach acid, example due to atrophic gastritis or, very commonly, PPI therapy.
So how do you confirm ZES?
If FSG is very high, 10 times the upper limit of normal, and the gastric pH is low, 2, confirming acid hypersecretion, the diagnosis is made. If FSG is moderately elevated, a secretin stimulation test is performed. Injecting secretin paradoxically causes a significant rise in gastrin levels in ZES patients, unlike other causes of hypergastronemia. PPIs must be stopped for at least a week before testing.
And screen for MEN1.
Absolutely. All patients diagnosed with ZES should be screened for MEN1 with biochemical tests, calcium, PTH, prolactin, and potentially genetic testing.
Localization.
It can be challenging because the tumors, especially duodenal ones, are often tiny and multiple. Somatostatin receptor imaging, SRS, particularly 60-8-adotate PET-CT, is highly sensitive because most gastrinomas express SSTRs. EUS is also valuable for detecting small pancreatic or duodenal wall tumors.
Treatment.
Medical management with high-dose proton pump inhibitors, PPIs, is extremely effective at controlling the acid hypersecretion and healing ulcers. This is the mainstay and often required lifelong, even if surgery is performed. For patients with metastatic disease, somatostatin analogs can help control symptoms and may have some anti-tumor effect. Surgery is generally recommended for patients with sporadic ZES without distant metastases, aiming for cure. This often involves exploring the gastronoma triangle, removing the primary tumors, and dissecting regional lymph nodes. For MEN1-associated gastrinomas, surgery is more controversial, especially for small 2-centimeter duodenal tumors, as they are often multiple and cure is less likely. PPIs are the main treatment. Parathyroidectomy in MEN1 patients, for their hyperparathyroidism, can also help reduce gastrin levels and acid secretion.
What about non-functioning PNETs, NF-PNETs?
These are actually the most common type of PNET, making up 60–90% of cases. They are defined by the lack of a clinical syndrome caused by hormone hypersecretion. Pathologically, they might still stain positive for various hormones, but they don't release enough to cause symptoms. They do typically stain positive for general neuroendocrine markers like chromogranin A and synaptophysin.
How do they present?
Because they don't cause early hormonal symptoms, they are often diagnosed later when they become large enough to cause mass effect abdominal pain, jaundice if compressing the bile duct, weight loss, or pancreatitis. Sometimes they're found incidentally on imaging or present first with liver metastases. Blood tests might show elevated chromogranin A or pancreatic polypeptide levels, but these are nonspecific. Imaging, US, CT, MRI, usually finds a pancreatic mass, often quite large, 5 centimeters. A key diagnostic challenge is distinguishing NFP nets from the much more common and aggressive pancreatic ductal adenocarcinoma, as the prognosis and treatment are vastly different. NFP nets generally have a much better prognosis. Biopsy, often via EUS, is usually needed to confirm the neuroendocrine nature and determine the grade. Chi 67, SSTR PET scans are often positive and useful for staging.
Treatment strategy.
Guided by tumor grade, stage, and symptoms, algorithm figure 57.1 cent. For localized resectable tumors, surgery is the primary treatment, aiming for cure. Depending on location and size, this might involve major resections, like a Whipple procedure for tumors in the head, or potentially parenchyma-sparing resections, like enucleation or central pancreatectomy, for smaller, favorably located tumors. For unresectable or metastatic low-grade G1, G2 tumors, treatment options include observation, if asymptomatic and low volume, somatostatin analogs, which have antiproliferative effects, targeted therapies like everolimus or sunitinib, liver-directed therapies, embolization, ablation, or PRRT, peptide receptor radionuclide therapy. For high-grade G3 neuroendocrine carcinomas, NEC, platinum-based chemotherapy is the standard. Small, 2 centimeters, asymptomatic, incidentally found NFP nets can sometimes be managed with active surveillance.
Okay, let's move to GI nets arising outside the pancreas. Stomach nets first.
Gastric nets are rare. The source describes 3 main types based on the underlying stomach environment. Type Y, 70 to 80%. Associated with chronic atrophic gastritis, often autoimmune, leading to high gastric pH and consequently high gastrin levels. These high gastrin levels stimulate ECL cells, a type of neuroendocrine cell in the stomach, to form small, multiple polyps or nets, usually low-grade and benign. Type 2, 5%. Associated with VES, a gastrinoma elsewhere, causing high gastrin levels, which again stimulates ECL cells. Also typically multiple polyps, low grade. Type 3, 15 to 25%. Sporadic, not associated with high gastrin. These tend to be larger solitary tumors, often more aggressive, behave more like typical gastric adenocarcinoma, and frequently present with metastases.
Presentation and diagnosis.
Type I often found incidentally during endoscopy for dyspepsia, or presents with anemia due to B12 deficiency from the atrophic gastritis.
Yeah.
Type 2 presents with ZES symptoms. Type 3 might present with bleeding, pain, or symptoms of metastatic disease. Diagnosis is by upper endoscopy with biopsy. EUS helps assess depth of invasion. Staging involves CT and potentially SSTR imaging.
Treatment varies by type.
Yes. Type 1. Treat the B12 deficiency. Small polyps, 10 millimeter, can often be monitored or endoscopically removed. Larger ones may need surgical excision. Type 2. Treat the underlying ZES, PPIs plus hydrogastrinoma resection, and endoscopic surveillance removal of gastric polyps. Type 3. Treated aggressively like gastric adenocarcinoma, usually requiring surgical resection, partial or total gastrectomy, with lymph node dissection.
Duodenal nets.
Even rarer, maybe 1-3% of GI nets. Usually small, 2 centimeters, found in the submucosa, can be non-functioning or functional. The most common functional type is a gastrinoma, often associated with MN1. Somatostatinomas can also occur, sometimes associated with NF1. Diagnosis via endoscopy use imaging, check relevant hormones, screen for genetic syndromes. Treatment for localized tumors is typically endoscopic or surgical resection. Gastrinoma is managed as discussed under ZES.
Small intestine nets, the midgut carcinoids, these are more common.
Yes, historically one of the most common sites, table 57.6, and the second most common malignancy of the small bowel after adenocarcinoma. Peak age 60-70s. Arise from enterochromaffin cells, often producing serotonin and substance P.
Characteristics.
Can be solitary or multiple, 30%. The primary tumor itself is often surprisingly small, maybe 5-20 millimeters, and can be hard to find, figure 57.17. Despite their often indolent growth, they frequently metastasize early to regional lymph nodes, 36%, and the liver, 48%. It's often the metastases that cause symptoms and lead to diagnosis.
What symptoms do they cause?
Vague, intermittent abdominal pain is a very common early symptom, sometimes present for years before diagnosis. If liver metastases develop, about 20–30% of patients will experience carcinoid syndrome, flushing, diarrhea, wheezing. Another characteristic issue arises from the lymph node metastases in the mesentery, the tissue anchoring the bowel. These often provoke a strong fibrotic reaction, desmoplasia, that can encase and constrict the mesenteric blood vessels, leading to bowel ischemia, pain, and altered bowel habits, figure 57.18. Sometimes diagnosis occurs incidentally during surgery for something else or when investigating liver mets. Elevated 24-hour urinary 5-HIAA is highly specific for serotonin-producing tumors causing carcinoid syndrome. Chromogranin A is often elevated but nonspecific. Cross-sectional imaging, CT-MRI, is key for staging looking for the primary, though often hard to see. The characteristic mesenteric nodal mass with radiating strands due to desmoplasia and liver metastases. Biopsy, usually of a liver met, is essential to confirm the diagnosis and, crucially, to determine the Chi-67 grade, which is a major prognostic factor. SSTR PET, like 68 gadotate, is very useful for staging and locating the primary tumor if it's not seen on CT-MRI. Patients with suspected carcinoid syndrome should also have an echocardiogram to evaluate for carcinoid heart disease.
Treatment follows a structured approach.
Yes, the ENETS guidelines stratify management based on stage, summary box 57.3. For localized disease, stage every 3, no distant mets, surgery offers the only chance of cure. This involves resecting the segment of small bowel containing the primary tumor along with its draining mesenteric lymph nodes. Achieving a complete R0 resection is the goal, though the mesenteric desmoplasia around the superior mesenteric artery vein can sometimes make this challenging. Because long-term treatment with somatostatin analogs can cause gallstones, removing the gallbladder, cholecystectomy, at the same time is often considered.
What about metastatic disease, stage 4?
Surgery might still play a role, either palliatively, for example, to relieve bowel obstruction caused by the primary or nodal mass, or potentially with curative intent if all disease, primary nodes and liver mets, appears resectable, liver metastasectomy. Any surgery requires careful perioperative management with intravenous somatostatin analogs, like octreotide, to prevent a potentially life-threatening carcinoid crisis, massive hormone release, during anesthesia or tumor manipulation.
What are the non-surgical options for metastatic disease?
Liver-directed therapies like radiofrequency ablation, RFA, embolization or chemoembolization can help control symptoms and tumor burden in the liver when resection isn't possible. Somatostatin analogs, octreotide LAR, lanreotide autogel, are crucial for controlling the symptoms of carcinoid syndrome and also have proven anti-proliferative effects, slowing tumor growth in low-grade G1, G2, Chi-67 up to 10% disease. If the disease progresses despite SSAs, peptide receptor radionuclide therapy, PRRT, using radio-labeled assays, like lutetium-177 dotatate, is an effective option for SSTR-positive tumors. High-grade G3-NEC tumors are treated with systemic chemotherapy.
And appendiceal nets.
These are the most common tumor of the appendix, usually found incidentally after pennicectomy in about 3 to 5 per 1,000 specimens. Most are small, 10 millimeters, located at the tip, and low-grade. For these small tumors, simple appendicectomy is curative with excellent prognosis. However, for larger tumors, 20 millimeters, or those with invasion into the mesoappendix, 3 millimeter, or positive margins, an oncological right hemicolectomy, removing the right side of the corn, is recommended to ensure clearance of regional lymph nodes.
Finally, let's bring together several of these concepts by discussing the multiple endocrine neoplasia, MN syndromes. These are inherited disorders predisposing to tumors in multiple endocrine glands.
Exactly. They highlight the genetic links underlying some of these conditions. The two main types are MEN1 and MEN2.
Tell us about MEN type 1, Burmer's syndrome.
This is an autosomal dominant disorder affecting about 1 in 30,000 people. It's caused by mutations in the MNN1 tumor suppressor gene on chromosome 11, which codes for a protein called menin. The two-hit hypothesis applies. Individuals inherit one mutated copy, and a second somatic mutation in the other copy triggers tumor formation. There are many different MN1 mutations, but generally no clear genotype-phenotype correlation.
What tumors develop in MN1? Table 57.6.
The classic triad involves the 3 Ps: 1. Parathyroid glands. Primary hyperparathyroidism, PHDT, develops in almost all patients, 95%, usually due to hyperplasia of all four glands. This is often the first manifestation. 2. Pancreatic neuroendocrine tumors, PNETs. These are very common, found in up to 70% with screening. Many are non-functioning, but functional tumors also occur, most commonly gastronomas, causing ZES 30-80%, and insulinomas, 15-50%. 3. Pituitary tumors occur in 15-50%, often prolactinomas, secreting prolactin, treatable medically, or non-functioning adenomas. 3. Pituitary tumors. Other associated tumors include adrenocortical tumors, often non-functioning, 40-50%, neuroendocrine tumors of the parenchyma stomach, lipomas, facial angiofibromas, and meningiomas.
How does surgery differ in men 1, particularly for PHPT?
Because PHPT in N1 is typically four-gland disease, hyperplasia, the surgical approach differs from sporadic PHPT, usually a single adenoma. Patients require bilateral neck exploration to identify all parathyroid glands. The options are usually either subtotal parathyroidectomy, removing 3.5 glands, or total parathyroidectomy with autotransplantation of some tissue, usually into the forearm. There's ongoing debate about which is better. Patients need counseling about the high risk of persistent or recurrent hyperparathyroidism. Prophylactic removal of the thymus gland during neck surgery is often recommended due to the risk of thymic nets.
And managing the PNETs in men 1.
It's challenging due to the high likelihood of multiple tumors. Gastronomas, as we discussed, are often managed medically if small. Symptomatic functional PNETs, like insulinomas, are usually surgically excised if possible. Non-functioning PNETs are complex, balancing the need for resection, especially 2 centimeters, against the risk of causing diabetes or exocrine insufficiency due to multiple or major pancreatic resections. Adrenal tumors are usually resected if functional, rare, or 4 centimeters.
Now, M type 2, also autosomal dominant, but different gene.
Yes. MEN2 is caused by germline activating gain-of-function mutations in the RET proto-oncogene on chromosome 10. RET is a receptor tyrosine kinase involved in cell growth and survival pathways. Unlike MEN1, there's a very strong correlation between the specific RET mutation, genotype, and the resulting clinical features, phenotype.
What are the subtypes of MEN2? Table 57.8.
There are 3 main clinical variants. 1, MN2A, the most common type, prevalence 125,000. Characterized by medullary thyroid carcinoma, MTC, in virtually 100%, this is the main life-limiting tumor, phaeochromocytoma, PCC, in about 50%, often bilateral but rarely malignant in MEN2A, and primary hyperparathyroidism, PHPT, in about 20-30%, usually mild multi-gland disease, often not requiring surgery. 2, MEN2B, much rarer, 0.2/100,000, often arising from new mutations. This is the most aggressive form. Features include MTC, 100%, very early onset aggressive, PCC, 50%, but no PHPT. Instead, patients have characteristic physical features like a marfanoid habitus, tall, thin limbs, mucosal neuromas, bumps on lips, tongue figure 57.2 min, and ganglioneuromatosis of the gut. The link to MTC, FMTC. Considered a variant where MTC occurs in families due to RET mutation, but without the other features of MEN2A or 2B, no PCC or PHPT.
The link to MTC is central to MEN2 management.
Absolutely critical. MTC arises from the C cells of the thyroid. In MEN2, MTC development is preceded by a precancerous stage called C-cell hyperplasia. Because the risk of developing MTC is essentially 100% and is the main cause of mortality, identifying individuals with RET mutations through genetic testing allows for prophylactic thyroidectomy before invasive cancer develops.
Prophylactic thyroidectomy, removing the thyroid based just on the gene result.
Yes, it's one of the triumphs of predictive genetic medicine. The timing of the prophylactic thyroidectomy is guided by the specific RET mutation, which predicts the age of onset and aggressiveness of MTC, table 57.9. For the highest risk mutations associated with MEN2B, thyroidectomy is recommended within the first year of life. For lower risk mutations, it might be done later in early childhood, guided by mutation risk level and sometimes serial calcitonin measurements. Calcitonin is a marker produced by C cells.
Wow. And briefly, MN type 4.
A much more recently described and extremely rare syndrome, also autosomal dominant. Caused by mutations in the CDKN1B gene, it seems to overlap with MN1, causing parathyroid and pituitary tumors, but also potentially tumors of the kidney, adrenal glands, and reproductive organs. PNETs have also been reported. Management generally follows the principles for M1-related tumors.
So as we wrap up this incredibly detailed dive, let's circle back to those core principles of endocrine surgery we started with. We've really seen them illustrated across all these conditions.
Absolutely. That first principle, biochemical confirmation, is paramount. You saw how crucial it is for Conn's, Cushing's, PPGL, insulinoma, gastronoma. You can't rely on imaging alone. You need proof of hormone dysregulation.
And step 2, rendering the patient safe. We saw that with alpha blockade for PPGL, correcting potassium in Conn's, managing glucose and cardiovascular risk in Cushing's, treating adrenal crisis. It's all about minimizing perioperative risk.
Then localization. Imaging is key, but we saw the nuances, the limitations of CT and Conn's leading to AVS, the need for functional imaging in PPGL or NETs, the challenges of finding tiny gastronomas or insulinomas, and importantly, knowing when not to biopsy, like with suspected ACC or PPGL.
Deciding on surgery, step 4 was complex too. Based on function, size, malignancy risk, symptoms, genetic context like in MN syndromes, or just surveillance for small incidentalomas or NFP nets.
And finally, the operative approach, tailored to the specific pathology, laparoscopic versus open, transperitoneal versus retroperitoneal, enucleation versus major resection versus en-bloc resection for cancer. It requires judgment and expertise.
The repeated emphasis on the multidisciplinary team, MDT, also stood out. For incidentalomas, ACC, complex Conn's, PNETs, GI-NETs, MEN syndromes, these aren't conditions managed in isolation.
Definitely not. You need endocrinologists, surgeons, radiologists, pathologists, oncologists, geneticists, nuclear medicine physicians, all working together. And that close endocrinology follow-up post-operatively is vital too, for monitoring hormone levels, detecting recurrence, and managing replacement therapy.
This has been an incredibly comprehensive overview covering anatomy, physiology, specific disorders of the adrenal cortex and medulla, the diffuse neuroendocrine system in the pancreas and gut, and the genetic syndromes tying them together.
We've seen the critical role of biochemistry, the power and limitations of imaging, the nuances of medical versus surgical management, and the different surgical techniques employed. It really underscores how these often rare but significant disorders required a deep understanding of interconnected systems.
It's fascinating how symptoms can be so non-specific or intermittent, making diagnosis a challenge, and how genetics plays such a key role in predisposition and management, especially in man and hereditary PPGL syndromes.
It certainly highlights the need for thorough investigation and specialized care.
As you reflect on this deep dive, maybe consider this. How does that intricate balance of hormone secretion and feedback, so essential for keeping us stable, also create these specific points of vulnerability? When that control breaks down at a cellular or genetic level, it leads to this diverse spectrum of complex diseases. It truly makes you appreciate the body's delicate regulatory mechanisms.
A profound thought. The very systems designed for precise control become the pathways for disease when perturbed.
Thank you for joining us on the deep dive today. We hope you feel much more informed about this fascinating and complex area of surgery and endocrinology.